Hello, everyone, and welcome to another episode of Team from the Top, where we'll explore the future of healthcare through conversations with leaders shaping policy, innovation, and care delivery. My name is Christina Kenny, and I'm the Vice President of Clinical AI at Rainfall. And I'm also a registered nurse with 25 years of experience in healthcare leadership, quality improvement, patient safety, and clinical transformation. My career has also included an academic clinician scientist research role, both with Samsung Research America, UCSF, Stanford, and the VA Palo Alto and San Francisco as well, where I've focused very, very heavily on digital health, artificial intelligence, implementation science, and improving surgical outcomes for older adults. Today, I have the privilege of speaking with somebody whose career has influenced healthcare from nearly every perspective. Dr. David Shulkin served as the ninth United States Secretary of Veterans Affairs after previously serving as Undersecretary for Health, leading the nation's largest integrated health system. And throughout his career, he's worked at the intersection of medicine, healthcare operations, innovation, public policy, and value-based care. Dr. Shulkin, welcome. It's really an honor and privilege to have you with us today.
Well, I'm so glad to be with you. Thank you for having me.
Yeah, and just to kind of set the stage a little bit, and before we begin, I'm just going to go ahead and provide a bit of context for our listeners who may not be aware of what the CMS TEAM model is. On January 1st, 2026, CMS TEAM or CMS launched what's called the Transforming Episode Accountability Model, or TEAM, the first mandatory bundled payment model. And TEAM will run through December 31st, 2030, with performance here serving as the glide path, allowing participating hospitals to really learn to build the infrastructure needed for downside financial risk, which will begin very shortly here in 2027. And the model includes approximately 721 hospitals across 188 core areas, with the focus on very high volume surgical episodes, which include lower joint extremities, surgical hip and femur fracture treatment, coronary artery bypass grafting, spinal fusion, and major bowel procedures. It really represents one of CMS's clear signals, yet that value-based care is becoming the future of Medicare payment, rewarding hospitals not simply for the care they provide inside their walls, but for the outcomes coordination and recovery of older adult patients across the entire continuum of care. And so today's conversation isn't simply just about understanding teams. It's about understanding what team represents, but really where Medicare payment policy might be headed and how health care systems should start to prepare for this future. Now, Dr. Shulkin, you have sat inside federal health policy at the highest levels, and you've watched bundle payments evolve from voluntary pilots to now mandatory national policy. And I'd really like to leverage today's conversation from various angles to really help healthcare leaders understand not only what team is going to require and all the other emerging mandatory models that are coming down the pipe, but where all of this is ultimately going and what we should expect. Before we dive into the team model itself, it'd be really great just to learn a little bit more about you and your career and, as being part of the VA system, which is a very large the largest integrated health system, how leading that system really sort of shaped your thinking about quality, access, care coordination, and payment reform. So let's go ahead and maybe start there if you're comfortable with that.
Sure. Well, I had spent my career running private healthcare systems, academic and community health systems. And when I went into government, it was a very different payment model. The payment model, of course, is that as secretary, I would go to Congress and ask for the budget that I thought that we needed to be able to care for the country's veterans. And that money would be given. And then as secretary, I'd be responsible for overseeing how that money was given. But it really was for a defined population of veterans. So it was an accountable model where the money was given in a budget year, often 2 years up front, and we had to decide the best way to use it and then use those resources most appropriately, not only for caring for veterans, but for the taxpayers to make sure that the money was being delivered with value. The interesting thing about the VA is that it really is somewhat of a closed system. Once somebody enters the VA system, usually after transition from the military, the VA is responsible for them for the rest of their life. And even after life, since the VA maintains a memorial uh, administration where we bury the veteran and take care of that grave in perpetuity. So um, when you think about investing dollars in healthcare, you can think about not only the immediate impact it has on a veteran, but also the long-term impact that prevention has on future costs, sometimes decades down the road.
Perfect. No, thank you so much, and I really appreciate you sharing a little bit of a glimpse into your background and your story, and thank you for your time spent in serving in that position. I've had firsthand experience, working as a research fellow, research scientist, and fellow with the Veterans Affairs at San Francisco and Palo Alto, and it's just tremendous work that's being done. So thank you for much of the work that you also spearheaded while you were there. So, it's very striking to all of us, from the healthcare perspective. You're a physician, you're an executive, you've been a policymaker, secretary, and now you're an advisor and investor. Um, but you're very, from all of these different perspectives, that really makes you very uniquely qualified to discuss, some components of CMS and the CMS value-based model. So we really appreciate your time in having you here. So I do want to turn our attention a little bit more into understanding, why team matters specifically. Many organizations that we speak to still really view team as another payment model and not necessarily mandatory. And I personally think it's going to be a lot bigger than what healthcares are anticipating at this point. I think it's a glide path this year. I think, as we hit 2027 and people really start to feel the impact, I think there'll be different perspectives at that point. But, you know, I, as you've watched, bundle payments evolve from, the the pilots, the BPCI and CGR, and now team. I mean, what do you think has changed? I mean, why now? Why mandatory? Do you believe that, was voluntary participation simply not enough? Was there something that you think really drove, these models to really become mandatory? I think a lot of our healthcare systems are really interested in hearing a little bit more about that. It'd be great to hear your perspective.
I think it's simply a calendar issue and a math problem. The calendar issue is that CMS has said that by 2030, they're going to have every Medicare beneficiary in a value-based payment model. And if you take a look at the calendar and we're halfway through 2026, there's no way that's going to happen on a voluntary basis, or if we continue to enroll beneficiaries in these programs at the rate that we're enrolling it. It just simply won't happen. And so you're going to have to start forcing more hospitals, more providers, more beneficiaries into these models if you're going to remain committed to that goal of getting every beneficiary into a value-based model by 2030. Now, one of the things that I think we've all been watching very carefully is whether the current administration backs off from that objective, because frankly, it was set during the Biden administration. And so many of the policies that were set in the Biden administration, the current administration has walked back and set their own goals. But we have not seen that. We've not seen them walk away from that. And I think the reason for that is the second part, which is a math problem. The Medicare trust fund will become unsustainable now in 2034. To many people, that sounds a long ways away, but it actually is not that long away. And with more people turning 65 every day, 10,000 Americans turning 65 every day, and the birth rate in the country going down, the problem is that this is an unsustainable model of putting people on Medicare at age 65 and being able to pay for it in the way that we're paying for it. So if you're going to address that problem, you're going to have to change the way that the government pays for healthcare. And frankly, this is a problem for the commercial sector. The burden of increasing healthcare costs is significant as well. So I think that the idea that value-based payments are going to get there on their own through a voluntary model, or that we have other solutions that are going to replace this. I think that the time was just running out, and the government said, we better start imposing this model and getting the provider community experienced with this so that maybe they'll feel more comfortable in accelerating the path towards value.
I'm I'm so glad that you addressed that component. It's something I've encountered, often in my research in the geriatric population is that we're really we're encountering or getting ready to encounter a true supply demand mismatch between available providers and the aging population. And I do think that, although value-based team models, there's a real heavy foundational component that really encourages teams meaning the hospital care systems, to think about coordination of care, to think about the episode beyond the inpatient care setting, to really think about what does coordinated care look like. And once it's tied to funding, that actually, really promotes people to want to do these things and to work together, a bit more closely, so that care can be safer and more seamless across the entire care continuum. Like in the case of Team, CMS Team, many of these surgeries, even these larger surgeries, and I've been around and rolled out programs like enhanced recovery after surgery, which have been across large organizations like Kaiser Permanente, where we were able to, decrease length of stay, improve outcomes like opioid consumption, and people were going home. But it was quite interesting because we started sending them home sooner, which was a huge savings, and they were doing better outcomes. And this is, of course, all supported in the research literature. But then we would send them home, and that wasn't really a component that we had thought about too much. Like, how do we need to support and coordinate care beyond home care services and skilled nursing? So in this environment, it's really thinking that we're challenging, the conventional way that things had always been done, I think. And I think the team model and the upcoming CGRX model that the Trump administration is proposing for 2027 is also going to further, um, I believe, um, really focus attention on coordination of care and what's the role of technology and, helping to fill some of those gaps as well. So policy is one thing, but successful implementation inside a healthcare system is something, entirely different. So I want to spend just a few moments talking a little bit about the operational realities, and what that might look like. And I'd love to get your thoughts, on that if you're open to it. So I can just kind of start out. What operational capabilities do you believe might separate hospitals that will thrive under CMS team model versus those who might struggle?
Well, the issue clearly, I think, is having a new way of designing care once the patient finishes the surgical procedure and leaves the hospital, so that this includes an extended period of time, 90 days outside of the hospital setting. And that's something that is traditionally thought of as not within the control of the hospital, because the patient leaves, goes into other organizations, or as you said, into the home care setting, and hospitals just have simply not thought about that as their responsibility. But under this model, they are financially and clinically responsible for that. So that's going to take a whole new redesign or way of thinking about the period of time that the hospital now bears responsibility for the result of that surgical procedure.
Correct. It's going to require coordination and communication that differs a bit from what we see today, although it's in place with skilled nursing and post acute. But in my own research, I've seen, there's the family caregivers and the patients themselves. And oftentimes we're dealing with older adults who are going to surgery, which we can consider an acute event, but oftentimes they have two or more chronic conditions on top of that. And then you have a caregiver who traditionally um, is an older adult spouse as well. So that just kind of adds complexity. And so it does require, what does that journey look like and how do healthcare systems need to seamlessly support care systems all the way into the home setting so that patients and their caregivers are fully prepared so that we can, think about optimizing the recovery at home. So I want to shift a little bit from direct hospital operations and talk a little bit. You had mentioned, you touched upon, older adults, the older adult patient, and how that's shifting. And perhaps, the 65 and older is the most affected population by value-based models, at least at this point. Um, so, teams sometimes healthcare systems are so focused on the financial performance that they lose sight of, the patient at the center of the episode and the patient outcomes. And I'd really love your thoughts, in really understanding from your perspective, like we have a lot of the CMS measures that are out that we're tracking very closely under teams, the quality measures, readmissions, and so forth. But kind of turning specifically to the geriatric population, do you see CMS eventually, moving towards, rewarding or optimizing, reconciliation for, you know, delirium prevention and functional recovery and in a way that's a little bit more robust than we see right now, maybe frailty assessments. I mean, there's all these sort of hot topics in the geriatric surgery world, that we've discussed with IHI and the American College of Surgeons, for example, as everybody starts to roll out another program, which is CMS age-friendly care. And so that's also front and center. Do you see that CMS will be pulling some of these things into value-based models, or do you think that's somehow going to stay sort of separate with like the age-friendly measure, or how do you see those align?
Well, I'm certainly not in the business of predicting what CMS is going to do. All that I can do more accurately is look backwards. The vast majority of the models that CMI has tested in the past have really not turned out to be extremely cost effective in terms of achieving the types of savings that I think that CMS was hopeful for. And so those analyses of past CMMI models have found that only a few have been very successful. Now, that has included bundled payments. And so I think that what we're seeing now is we're seeing CMS say, well, maybe we shouldn't be as experimenting as much. Maybe we should be taking a point of view and doubling down on those programs that we know might be effective. So I do think that this Teams model is a very important program for them because not only is it fairly broad and is it mandatory, but they're going to see the results of this, relatively soon, a year from now. Let's say these results should be in with the reconciliation period after the calendar year of 2026. So I do think that if this is a successful program for them, they will expand it and they will uh, look for additional high cost categories to be able to move into. Now, some of the CNS disorders are some of the most challenging that we have because we just don't have very effective interventions or therapies at this point that are going to dramatically alter the course of some of these conditions like Alzheimer's, although there's encouraging research, but nothing that I think is similar to what happens with a surgical procedure when you come in with something that is blocked or broken and you can fix it and move on. I think those are going to be much more value-based interventions than in conditions that we just don't yet have those effective therapies.
And it gets to be quite complex, as I mentioned, you're really surgery is you're superimposing you know, a surgery on top of an older adult who oftentimes comes to the table with many complex, comorbidities as well. So it makes the situation oftentimes pretty complex, and these patients can be, you know, fairly high risk, especially as they sort of start to approach the 75, 80 um, age range. So thank you for your thoughts on that particular topic. I really appreciate it. I do want to pivot a little bit and move into sort of the topic of AI and digital health. So, healthcare has really spent decades, digitizing information. We're now seeing generative AI as a potential to help, make that information a bit more actionable, more visible, real time. You know, we're starting to see shifts away from reactive quality improvement where you conventionally collect the information, it's submitted to mandated reporting or, optional reporting. And then you react on data that's already older. But now, with generative AI and the electronic medical record and many other components, we're really starting to shift into like this more proactive, I believe, proactive approach, or at least I think that that's the goal so that it's real time quality improvement, real time quality care coordination and communication in the moment. Where do you think AI creates the greatest value in the CMS team model? Is it predictive analytics? Is it documentation? Is it care coordination? Is it quality reporting? Do you believe it's something potentially on the patient side, or coordination with outside skilled nursing and post-acute care facilities? Where do you think there might be some real value in leveraging, AI-enabled platforms as part of the CMS team model?
It's a good question. Obviously, AI is impacting potentially so much, but it really hasn't yet uh, infiltrated into the clinical decision making in the clinical world yet. We're seeing in hospitals AI applications mostly on the administrative or the back office side, or on things like documentation, coding, reimbursement, revenue cycle. But it's absolutely coming quickly into the clinical realm. I think it's going to impact, you know, care management and models like teams in almost all the ways that you mentioned. I think that better patient identification, who's appropriate for these therapies, and how do you essentially identify those that may need additional preoperative uh, optimization before they go through a surgical procedure. I think wherever there is data available and there are evidence based algorithms that can be matched up against that data, we can do a better job at learning more about patient identification and selection. I think predictive analytics is going to be very important. What are the um, appropriate settings when you leave the hospital? What type of care is needed when you leave the hospital? And that needs to be individualized. It can't be just a generic care pathway. I also think real time monitoring of data, as you said, is important. If you can identify a patient that may be going off of the expected recovery course early, then you have an opportunity to intervene with less resources than if you wait until there's a serious adverse event that requires them to come back to the hospital or to the emergency room. So I think we will see AI impacting all of these different areas, particularly where there have been blind spots in the past between different settings. When a patient leaves a hospital, often the post acute provider doesn't have access to all that information, or the people in charge of the care from the hospital don't have access to information in the home or to DME or pharmacy compliance. So there are a whole bunch of blind spots that currently exist because of the operational silos that we have, and I think that better data integration and management, and the use of AI as a real time monitoring tool, I think is going to be able to impact a lot of those areas.
Amazing. Thank you for your thoughts on that. It's super insightful, critical that we really try to unpack and understand what are the best use cases for AI? And I think there are just an enormous amount of opportunity of AI plus administrative reduction, burden of administrative burden reduction, as well as decision support. But I also think right into the patient home, supporting education and recovery and healing. And what does that look like? I think that there's just an enormous amount of possibilities there. So thank you for sharing. So, technology often follows incentives and innovation follows opportunities. So, I want to just kind of talk a little bit about where, given your background in investing and innovation, where you see healthcare innovation heading next. And so, what type of healthcare technology companies do you believe are best positioned to succeed under team or to really, sort of partner to enhance how healthcare systems and skilled nursing and all of the different key players, how they uh, may sort of improve under the team model.
Yeah, I think we've talked about wherever technology can play a role in giving visibility and decreasing the uh, barriers right now to full continuity of care, that's going to be important. So you're going to look at things like um, remote monitoring capabilities. You're going to look at new technologies and care management in the home setting. I think that's often the most cost efficient. And uh, wherever care can be better coordinated. But the care that's delivered is important, so it needs to be the right care, and you need to be able to start making sure that we're following what the evidence and what the science tells us is going to be effective and eliminating those resources that are being spent that don't add significant value.
Yeah. No, thank you for that. And it's a fascinating time with all of the AI and the technology that's emerging right now. I think that there's, one component that I think sometimes gets missed as well in an area, I was trained at the VA in the implementation science fellowship there for 3 years actually, which was a really eye-opening and wonderful experience. And I've worked, with large scale, complex health organizations like Kaiser Permanente. And, I sort of also sit on the space of what is it, that the technology may perform phenomenally, meaning the model is just mind blowing. But really, where the rubber meets the road is integration and implementation and adoption and change management really in the healthcare system. So I think that while we have this amazing, technology, which I think will continue to evolve to only get better, I think that we're also going to need to really start thinking about um, the implementation components and what does it take, to redesign systems to accommodate the new technology. So it's a fascinating time right now to be in healthcare and technology meets healthcare, in particular AI. So thank you for that. So,
Yeah.
this conversation, kind of naturally raises the broader question of Medicare itself and where they're heading. And so, from your perspective, what do you think Medicare payment? I mean, you touched upon it a little bit earlier, but what do you think Medicare payment will look like 5, 10 years from now? I mean, I think you touched upon it, but I'd like to maybe discuss that a little bit more.
Yeah, I'm not one who predicts the future very well. Medicare is not just a program that is run on the fiscal realities of the program, but it's one that obviously is very important in the political realm. And whenever you talk about things that involves politics and where Congress and the administration set the policies, it's very difficult to predict. We do know that Medicare will increasingly become an important issue. It already is, but even more important than it is to the voting bloc that is getting older. And so sustaining the program and not withdrawing benefits from the program is going to be paramount from a political perspective. Then the
Sure.
people running the program have to figure out a way, how do you pay for that? And that's where the complexity comes in. So there's going to have to be obviously a number of factors that look at making the program more affordable from a government point of view. we're seeing right now the administration focusing very heavily on fraud, waste, and abuse because that is a politically popular issue, which is nobody wants to see money being used inappropriately, certainly not illegally. So clamping down on that is important. The administration has identified very large targets for that. And while I think there is significant fraud, waste, and abuse in the system, I think it's going to be hard to achieve those types of dollar figures all from a fraud, waste, and abuse system. So there's going to have to be other hard decisions as well, uh, implemented in parallel. And those involve either decreasing the amount of money that's spent in the system. We're seeing that obviously in the Medicaid program right now. But there's going to have to be changes in the reimbursement model. And that's where I think the team model is going to be so instructive to see what, if any, impact this is going to have on the overall cost and quality of care. If this is a model that demonstrates that you can have savings in the system and at the same time improve the quality of care,
Yeah.
I think you're going to see a much more aggressive implementation plan for models like this.
Amazing. No, thank you for that. And right around the corner is what looks like CGRX. So we had anticipated that, CMS was going to sunset CGR, and that definitely did not happen. And not only was it not sunsetted, it was expanded as well. And it looks very similar in some respects to CMS team. So it does look like, at least, for the next 5 years, there's a real push, in the innovation center for these mandatory value-based models. So we've got the 721 uh, hospitals participating in team, and then you have what it looks like somewhere over 2,500 hospitals that will be mandated to participate in the CGRX program. So definitely interesting. So as we start to kind of close out this conversation, through, Dr. Shulkin, throughout your remarkable career, you've cared for patients, led hospitals, led the nation's largest integrated healthcare system. Um, and you continue advising organizations shaping the future of healthcare. So I'd like to just kind of close with, two questions. So the first one is, what's the one thing you wish every hospital CEO understood where Medicare payment policy is headed? Or simply, what do they need to understand about the moment that we're in right now with the value-based care and CMS team?
I don't need to tell my colleagues this. I think they know it, but I think that there needs to be, if you're leading a healthcare system, you have to have a current impatience and a desire to get better every day. And getting better every day means not relying on the status quo, but learning how you can more effectively deliver the care, how you can improve care to your communities. And that today is going to require uh, pushing on the systems to the point that they become a little bit uncomfortable and making sure that you're always doing it with the patient's interest in heart. But ultimately, if a system is not affordable and you can't continue to run your system on the reimbursement that is coming in, you're not going to be there. You're not going to be able to provide the access to your community that I know most hospital administrators, people who run these organizations are really focused on. And that is, not only continuing to be there for the communities, but continuing to improve the health of those communities. And so staying in touch with where reimbursement is going is important, but I think hospital leaders actually need to be ahead of that curve and pushing the envelope.
Perfect. No, thank you for that. And last question, I promise. Um, you've seen healthcare from the inside of the government, from outside as a physician advisor investor. What's the biggest blind spot in your opinion? What's the biggest blind spot healthcare systems still have about Washington and preparing for what might be coming next? Where do you think there's sometimes a disconnect? And I'll kind of give you an example. Oftentimes, when I speak with different clinicians or healthcare providers or healthcare systems, it's always really surprising to me that there are a good number of them that didn't even know that their hospital or the anchor hospital was a mandated participant of TEAM, CMS TEAM. So it's really mind blowing that some of these healthcare systems are not even aware or they're not moving very quickly. I'm not sure if it's just because we're in year one and it's a glide path. But in addition to that, not just with CMS TEAM, what do you think are the biggest blind spots they have about Washington and the policy that's coming down from?
If you're running these systems right now, there's so much noise. There's so many things going on that it's hard to stay up on everything. But I do think that if you're running a hospital system, it is important to be watching and keeping an eye on what is likely to be coming out of Washington, because the healthcare system is so large and complicated that it really does take its lead from government policy, and commercial payers and other organizations tend to follow what Medicare and other government agencies are doing because those tend to be mandatory. And so watching what's coming out and actually participating in the policy process, something that used to be thought of as nice to do if you had time, if you were a leader, I think now is becoming much more of an important, essential part of a job, to be paying attention to what's happening on a policy level. And, the example that I think that most hospitals are watching closely right now is the 340B payment issues, because for many, many systems, this has become an important source of revenue to be able to help in other areas of caring for underserved populations. And as we watch policy shift, people understand that it's not just that one policy, it's going to have a ripple effect throughout the organization. And it's the same with the Medicare eligibility issue. So I think that, in recent years, most hospital leaders understand the importance of participating in the political process.
Thank you so much for sharing that. And, thank you again, Dr. Shulkin, for sharing, your inner insights today and for all of your leadership. This has really been, a very insightful and outstanding conversation, and thank you to our audience who hopefully joins in for another episode of Team from the Top. And we really look forward to continuing these conversations as healthcare continues to evolve.
Thank you. Thank you very much.